We're bypassing the pleasantries and jumping straight into the catastrophic hemodynamic collapse of an amniotic fluid embolism. Mortality here is staggering, and your clinical recognition must be absolutely instantaneous. Let's get to it. The exact chronological sequence of an AFE is a highly tested mechanism, and here's the crucial takeaway. It is not primarily a bleeding disorder at onset. An anaphylactoid reaction to fetal antigens triggers sudden onset hypoxia and acute pulmonary vasospasm. This rapidly forces profound right heart failure. It's this catastrophic cardiopulmonary collapse that hits first, entirely preceding the onset of severe disseminated intravascular coagulation, or DIC. You have to definitively contrast AFE with placental abruption. Yes, both cause massive hemorrhage and shock, but the presentations are starkly different. AFE is marked by instantaneous respiratory failure and cardiogenic shock. Contrast that with placental abruption. Abruption presents with painful vaginal bleeding, severe uterine pain, and uterine hypertonus. It completely lacks the instant primary respiratory failure we just saw in AFE. Let's isolate the underlying metabolic variants. Both of these emergencies result in DIC, but the systemic triggers are diametrically opposed. In FE, the DIC is triggered systemically by that anaphylactoid reaction to fetal antigens entering the maternal circulation. But in placental abruption, DIC is a consumptive coagulopathy occurring secondary to retroplacental hemorrhage and massive tissue factor release. Let's apply this. Here's a third-order clinical scenario requiring immediate diagnosis and initiation of cardiopulmonary support. A multiparous patient in active labor suddenly seizes, becomes cyanotic, and begins bleeding heavily from all IV sites. What's the exact diagnosis? We need to ruthlessly dismantle the high-noise distractors here. The correct answer is exclusively AFE. The sudden seizure, profound cyanosis indicating immediate hypoxia, and subsequent IV site bleeding definitively match the AFE sequence. Distractor 1, placental abruption, fails. There's no mention of uterine hypertonus or severe pain, and it doesn't cause sudden cyanosis. Distractor 2, eclampsia, causes seizures, sure, but critically lacks sudden cyanosis and instantaneous hypoxia. Distractor 3, uterine rupture, presents with abdominal pain and a sudden loss of fetal station, which is entirely absent here. And distractor 4, placenta previa, presents with painless bleeding but without sudden cardiogenic shock unless massive hemorrhage has already occurred. Module 2, Massive Transfusion Protocol and Citrate Kinetics. We're executing an immediate cognitive shift into trauma resuscitation to analyze the lethal metabolic traps hidden within massive volume replacement. When your trauma patient is in severe hemorrhagic shock, the Massive Transfusion Protocol is activated. You must strictly enforce the 1-to-1-to-1 resuscitation matrix. That's 1 unit of packed red blood cells to 1 unit of fresh frozen plasma to 1 unit of platelets. Aggressive inclusion of FFP and platelets is absolutely mandatory to prevent dilutional coagulopathy during massive volume replacement. This illustrates the exact consequence of failing that protocol. Look at the clinical findings. 6 hours after admission for a pelvic fracture, receiving 15 units of packed red blood cells and 8 liters of crystalloid, but crucially, no platelets, the patient bleeds from all catheter sites. The exact mechanism here is dilutional thrombocytopenia. Neither packed cells nor crystalloids contain platelets, leading to a profound acute coagulopathy directly secondary to dilution. Now let's unmask the citrate toxicity trap. Banked blood contains high concentrations of citrate as an anticoagulant. During rapid infusion, you're delivering an excess citrate load. This citrate actively chelates the patient's serum ionized calcium. The immediate lethal biochemical result is severe hypocalcemia. You must recognize the discrete markers of this severe hypocalcemia. The electrocardiographic hallmark is a prolonged QT interval. Clinically, you'll see worsened hypotension, tetany, muscle spasms, and the classic Chovestic and Trousseau signs. The absolute management step to stabilize the cardiac membrane and hemodynamics is prophylactic administration of intravenous calcium gluconate or calcium chloride. Here's a high-stakes trauma simulation targeting exact biochemical crossover points. A trauma patient receiving MTP develops worsening hypotension and a prolonged QT interval on their ECG, despite adequate volume resuscitation. Identify the exact electrolyte derangement. Exhaustively defending the correct answer here. Hypocalcemia caused by citrate toxicity is the only derangement fitting both the MTP scenario and the prolonged QT interval. Let's dismantle the distractors at a fourth-order reasoning level. Distractor 1, hypomagnesemia, can cause arrhythmias, but with rapid banked blood infusion, citrate-induced hypocalcemia is your primary threat. Distractor 2, hyperkalemia, is a real risk with hemolyzed banked blood, but it causes peaked T waves, not a prolonged QT interval. Distractor 3, dilutional thrombocytopenia, causes mucocutaneous bleeding, not QT prolongation. In Distractor 4, TRALI presents with fever, cyanosis, and bilateral pulmonary infiltrates, not an isolated prolonged QT.
Module 3, Fetal Heart Rate Kinetics and Resuscitative Hysterotomy. Transitioning relentlessly into our final module, bridging obstetrical operative thresholds with emergency resuscitative medicine.
You must correlate fetal heart rate tracings with their exact physiological failures. Late decelerations point directly to uteroplacental insufficiency. Variable decelerations indicate cord compression. A Category 3 tracing is defined by absent baseline variability combined with recurrent late or variable decelerations. The initial immediate steps for intrauteral resuscitation are maternal left lateral decubitus positioning, supplemental oxygen, and intravenous fluids.
The crucial point is this. If those initial intrauterine resuscitation steps fail and a Category 3 tracing persists uncorrected, expectant management is absolutely contraindicated. Emergent cesarean delivery becomes an absolute necessity. But what happens in the event of maternal cardiopulmonary arrest, perhaps secondary to the AFE we discussed earlier? This is the perimortem exception. You must initiate a strict 4 to 5 minute timeline. A resuscitative hysterotomy must be performed. The precise physiological mechanism here is that removing the fetus and placenta relieves aortocaval compression, which allows the restoration of maternal venous return.
Let's test this with the ultimate high-stakes perimortem scenario. A pregnant patient at 36 weeks suffers sudden cardiac arrest. What is the primary physiological goal of an immediate bedside cesarean section? The correct answer is to relieve maternal aortocaval compression to optimize chest compressions. We have to destroy the assumption that a perimortem C-section is strictly for fetal salvage. Distractor 1, primary fetal salvage is clinically incorrect in maternal arrest algorithms. Distractor 2, prevention of amniotic fluid embolism is an illogical trap. AFE is a cause of arrest, not prevented by post-arrest delivery. Distractor 3, reversal of the DIC cascade is entirely irrelevant to the immediate mechanical goals of CPR. Finally, Distractor 4, definitive treatment of severe preeclampsia is true for a living patient, but in cardiac arrest, the primary goal is purely hemodynamic restoration. We'll conclude this explainer with a lethal, dual pathology clinical trap. A patient receives 15 units of PRBCs and 8 liters of crystalloid after severe trauma. They rapidly develop a prolonged QT interval and simultaneously begin bleeding heavily from all IV sites. What are the 2 simultaneous immediate management steps required to save this patient? The high-yield teaching answer leaves 0 room for error. You must immediately administer platelets to reverse the dilutional thrombocytopenia and simultaneously administer intravenous calcium gluconate to counter the citrate-induced hypocalcemia. Mastering this dual recognition completely secures a perfect 270-plus clinical protocol. In resuscitative medicine, knowing the isolated facts isn't enough. Your ability to anticipate these compounding lethal cascades is what will ultimately save your patient's life. Keep integrating, and we'll see you in the next explainer.